The purpose of this video is to demonstrate a general screening neurological exam in patients who are asymptomatic. Other videos will demonstrate a detailed component of the neurological exam in patients with normal neurological findings and patients with neurological conditions. The neurological screening exam consists of a brief language assessment, cranial nerve examination, motor sensory examination in the upper and lower extremity, as well as coordination and gait assessment.
We will start with a language exam focusing on comprehension, repetition, and naming.
Fluency can be determined during history taking and is not formally assessed in this screening examination. Reading and writing is also part of a language assessment, but typically not performed in a screening neurological exam of an asymptomatic patient.
Good morning, Isobel. I'm Dr. Beckman. Nice to meet you. So we'll start with checking your language. Well, what I'd like you to do is close your eyes. Excellent. And point to the surface that we walk on. Very good. And I want you to repeat this sentence for me. No ifs, ands, or buts.
No ifs, ands, or buts.
That's excellent. Okay, I want you to name this object.
A watch.
Okay, and what part of the watch is that called?
Winder.
Very good. Okay, excellent.
There are 12 cranial nerves. The first cranial nerve, or olfactory nerve, is typically not assessed during a screening neurological exam.
We'll continue testing the cranial nerves: optic, oculomotor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, and the hypoglossal nerve.
The integrity of the second cranial nerve, or optic nerve, is assessed with pupillary light reflex, swinging light test, fundi examination, visual field testing, and visual acuity assessment.
So the next thing I'm going to do is going to check your pupillary light reflex. So look straight ahead there, Isobel.
When testing the pupillary light reflex, the patient should look at a far distance to avoid normal eye convergence, accommodation, and pupil constriction.
And I'm going to shine the light in the right eye, and the pupil reacts very nicely. Shine the light in the left eye, the pupil reacts very nicely. And now I'm going to do a swinging light test. Just look for a relative afferent pupillary defect. So you shine the light in that eye, pupil constricts. Come back to that eye, pupil constricts, and you can do it a number of times. And what you're looking for is to make sure the pupil constricts each time the light source goes towards the eye rather than dilates up. And that's nice and normal, so there's no evidence of an afferent pupillary defect. Next thing I'm going to do is have a look in your eyes. So, Isobel, what I'm going to do, I want you to look straight ahead for me. So,
look through the pupil to the back of the retina to visualize the fundi. Look specifically at both the optic disc and macula.
Come in from the side, and then you turn right in, and she has a very nice normal optic disc. Now I'm going to look in her left eye. So I've now switched the ophthalmoscope to my left hand, so left hand, left eye. So we'll do the same thing. Straight ahead. And that's perfect. And as you can see, as I'm holding the ophthalmoscope, I have my index finger on the lens so I can move it around very easily. So the next thing I'd like to test is your visual fields. So let's do central vision first. Cover up one eye. And do you see me clearly?
Yes.
Mustache, everything good. Cover the other eye. And do you see me clearly?
Yes.
Great. Okay, so let's check your peripheral visual fields, and I'll do finger counting as the first way of doing it. So I'm either going to hold up one finger or two fingers, okay? So, and I want you to cover one eye, and as soon as you see the fingers, tell me how many I'm holding up. So here we go.
1, 1, 2, 1, 1, 1.
Excellent. Cover the other eye. Well done. And same thing.
1, 1, 2, 1, 1.
Excellent. Okay. So I'm going to check her peripheral fields another way with finger wiggling. So when you see the finger wiggling, I want you to say yes, but not the arm moving, just the finger wiggling. Okay. So cover up one eye for me. And here we go.
Now. Now.
One can pick which
No.
technique to use for peripheral visual field testing, finger counting or finger
Yes.
wiggling.
Yes.
Great. Cover the other eye. Same thing.
Now. 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 Yes. Yes.
Well done. Very good. Okay. So I'm going to check next your visual acuity. So what I want you to do as well as cover one eye and grab the card with your opposite hand. And you can bring as close or far away as you want. And I want you to read those small numbers there.
428739.
Very good. Cover the other eye. And I want you to grab the card and read these letters for me.
OOX.
Excellent. 20/20 vision reading, both sides. Very good. So the next thing I'd like to do is do your extraocular muscles movements. So I want you to follow my finger with your eyes. So horizontal smooth pursuit is normal, and I'm going to go through the H pattern to make sure all the extraocular muscles are moving properly, and they are. So nice normal smooth pursuit. Next thing I'll do is check your saccadic eye movements. So I'm going to hold up the finger, I'm going to dart your eyes back and forth. So here we go. So look at the finger I'm holding up.
Ask the patient to move their eyes to the finger that is moved or wiggled while keeping their head straight.
Good. Let's try the other side now, okay?
Look at the accuracy, speed, and latency of the eye movements.
So nice normal horizontal saccades, and we'll do up and down now, okay?
Okay.
Very good. And now we'll do down. So nice normal saccadic eye movements.
In this screening neurological examination, you can assess saccadic eye movements by visual stimulus or by command.
Isobel, move your eyes to the left, move your eyes to the right. Look straight at me, look up at the ceiling, okay, and look down at your toes. Very good. So nice normal saccadic eye movements. So the next cranial nerve I'd like to test is the fifth cranial nerve. And Isobel, do you have any numbness or tingling anywhere?
If the patient notes numbness in their face, then a detailed examination of the trigeminal nerve is required. Detailed trigeminal nerve examination will be in a separate cranial nerve video.
No, not
On your
right now.
face?
No.
No. Very good. So I'll just do a bit of a screen with light touch only. I won't do pinprick. So you feel this, obviously.
Yeah.
So this is V1, V2, and V3. And V1, V2.
Ask the patient if the sensation to touch or pinprick is the same and normal on both sides.
So I want you to open your mouth for me. And I'm looking to see if her jaw deviates, and that's a quick way of testing her motor 5, and her jaw is very symmetric. Thank you very much. So I'm going to check now her seventh cranial nerve. So bring your eyebrows up and down. Great. It's nice and normal frontalis. I want you to close your eyes really tight. And I'm going to try and overcome them. They're good, strong orbicularis oculi, good, strong muscle. I want you to show me your teeth. Great. And so muscle of facial expression normal. I want you to put your lips together nice and tight, hard as you can. So orbicularis oris is nice and strong. Very good. So seventh cranial nerve appears to be nice and normal. I'm going to check your hearing now. I want you to close your eyes. And I want you to tell me which ear you hear this in, the right, the left, or both.
Both.
Very good. Okay. So I'm going to look in her mouth. Isabel, I want you to open your mouth for me. So I want you to say ah.
Look for symmetric palate elevation, and the uvula stays midline when she says, ah.
And then I watch her palate elevate symmetrically. And while I have her mouth open, I'm looking at her tongue. It's nice and quiet. It's not moving around. No atrophy noted. Okay. So I'm going to check your 11th cranial nerve now. I'm going to check sternocleidomastoid. So turn your chin into my hand.
Ask the patient to push against your hand as you note the contralateral sternocleidomastoid, or SCM, muscle bulk. The left SCM turns the head to the right.
And she has nice normal bulk. Turn your chin here, nice normal bulk. Right. Very good, thank you. Then I'm going to check her trapezius, and I look for symmetry of movement. So bring your shoulders up and down about 2 or 3 times. Very good, and it lifts symmetrically, so that's fine. So I want you now to stick your tongue out for me. And it looks nice and symmetric, doesn't protrude to one side or the other. Thank you. Close your mouth. Put your tongue in your cheek, and that's nice and strong, and do the other side, and that's nice and strong. So 12th cranial nerve is normal. So that's her cranial nerve exam. I would like you to hold your hands straight out in front of you, and I want you to close your eyes. Just keep them nice and still. I'm just going to look at you there. So nice, solid, hands not moving, and that's totally normal. So I'm just we'll demonstrate what pronator drift would look like. So Isabel, with your right hand, pretend there's a pronator drift. Yeah. Yeah, perfect. Okay. And then I'll show you what a sensory drift is if she doesn't have any proprioception in the hand. So go ahead, Isabel, show us what a sensory drift looks like. And the fingers might wiggle a little bit because she doesn't know where they are in space, and the hand drifts away. So there, that's excellent. Well done. So next thing I'm going to do is I'm just going to look at your muscles, okay? So great. Okay, good. So you look at muscle bulk, normal. I don't see any fasciculations. You want to look at the hands as well again, normal bulk. No wasting fasciculation, so that's all nice and normal, and there's no abnormal movements, tremors, or anything else noted. So, okay, so we'll carry on with our motor exam. So next thing I'm going to do is test power.
When testing muscle strength, you can show or help the patient into the position that would test that particular muscle, and then ask them to resist your action or hold that position.
So I want you to hold your arms up nice and strong, and don't let me push you down, okay? So here we go. Ready? So you always load the muscle and try and break it. Okay, so put that one down. So biceps, pull right in hard as you can. So I can't break her biceps, nice and strong. Triceps, you give yourself the mechanical advantage. That's one exception to the rule. So now you push me away hard as you can. And that's triceps, and she's nice and strong there. So pull right in, load the biceps, try and break it. Triceps, give yourself the mechanical advantage, nice and normal. And then make a fist, bring your hand up, hold it up strong, so wrist extension nice and strong, finger extension nice and strong. Bring your thumb up, hold it up, so abductor pollicis brevis, nice and normal. Always test it proximally, not distally. You give yourself the mechanical advantage that way. Little finger out, keep it out again, nice and normal. And spread your fingers hard as you can. Intrinsics nice and normal. Okay, let's do the other one. Make a fist, hand back, hold it back nice and strong. Great. Fingers straight, finger extension, nice and strong. Again, you don't try and break it distally. You try and put the pressure on proximally, or at least mid-fingers. Bring your thumb up, hold it up nice and strong. Good. Little finger out, keep it out. Abductor digiti minimi, nice and normal. And spread your fingers hard as you can. Excellent. Okay, so then I want you to wiggle your fingers for me, so fine finger movements. Because people who have corticospinal involvement or extrapyramidal involvement will have abnormalities of that. And then the other way of testing it, you can just flick water off your hands and watch how rapid the hand movements are, and they're nice and normal. Again, with the patient's arms resting on their laps, so they're nice and relaxed, and you feel normal tone. So I'll check and make sure she doesn't have a pronate or catch. So start with the hand pronated and try and forcibly supinate just once. And what you'll see, if hers is nice and normal, but if it's abnormal, what will happen is you'll see a catch. It'll look like that, but hers doesn't. That's all you do, and that's normal tone. Then I'll do reflexes, biceps, brachioradialis, and triceps. Again, I'm supporting Isabel's hand and doing her triceps. I end up switching position of my reflex hammer to do this, and again, I'm staying in front of the patient. Now, I can bring out her reflexes by doing a Gendrastic maneuver. So when I tell you to clench your teeth, but not until I tell you. So ready, clench, relax, ready, clench. And you can see the brachioradialis, ready, clench. Good. And then the triceps, you can bring out a little bit more. Ready, clench. Okay. Maybe I'll just expose the triceps a little bit here for people to see. And again, I'm holding her arm. And ready, clench. And that's a nice triceps reflex. Very good. Okay, so I do the reflexes in the lower extremity while the patient's sitting. Again, I palpate or feel for the tendon. Some people's tendons have moved over to the side, so you got to make sure you're hitting the right spot. And again, Isabel's reflexes are a bit low, but normal. We can enhance them with the Gendrastic. So when I tell you to pull, you pull. Okay? Ready, pull, relax, perfect. Ready, pull, relax, perfect. Ready, pull, relax, perfect. Ready, pull. Okay, very good. So nice, normal, symmetric reflexes. There's no hyperreflexia or asymmetric reflexes, and that's what we're looking for. Next thing I'm going to do is check your coordination. So I want you to take your finger, touch your nose, touch my finger, and go back and forth. Make sure the patient extends their arm out. So it's rate, rhythm, direction, force, nice and normal. And do the other hand for me. You can move it around a little bit, and she's nice and accurate. So nice coordination in the upper limb. First thing you want to do is you want to inspect the muscles like we did in the upper extremity, looking for bulk, looking for fasciculations or atrophy or any abnormal movements or tremor, and clearly you don't see any. You look at the thighs, you look at the lower extremities, and that's all perfectly normal. The next thing I'm going to test is tone. So what I do is I put my hands between the knees like that and lift up quickly. And normal response is what Isabel's doing is her heel will scrape along the bed, and that's normal tone. Okay. Next thing I check is clonus. So again, clonus needs to be tested where you bend the patient's knee, hold the foot with your hand like I'm doing, and then you forcefully dorsiflex the foot. And if she had clonus, what would happen is as you're dorsiflexing, the foot would keep doing this, and that's called sustained clonus. And you do it with the other one. So again, bend the knee and forcefully dorsiflex, and it's nice and normal, no movements noted. That's excellent. Okay, so what I'm going to do is check your strength now. So I want you to lift this leg straight up in the air. And again, load the muscle and try and break it. This is her hip flexor. Good, nice and normal. And lift this one up, hip flexor, try and break it. Nice and normal, very good. And bend your knee. And this is her hamstrings. Hold it nice and tight. So try and break the hamstrings, nice and normal. Now I'm going to check her quadriceps. And then I'm giving myself the mechanical advantage, so starting with her knee bent, and she's going to lift her leg straight out now. Nice and normal. Bend your knee, hamstrings, load it, try and break it, and quadriceps, again, give myself the mechanical advantage, and nice and normal. Very good, thank you. And I'm going to do ankle dorsiflexion, bring your foot all the way back and hold it there, and you try and go down and in and try and break it, and that's nice and normal. And I can do her big extensor hallucis longus, so bring your toe right back. Good, relax, and bring your foot right back and hold it there. Good, down and in, try and break it, nice and normal, and keep your big toe back. Again, nice and normal there. Perfect. So the next thing I'm going to do is just check your Babinski response. Again, the Babinski is done by scratching the outside of the foot and bringing it around to the front. So again, the normal response is the toes would go down or not move. And so we start out laterally and bring it up and in. And again, you don't see any response or a little bit of flexion response, which is normal. And on this one, again, start laterally. And the toes don't move or go down. That's perfectly normal. So the next thing I'm going to do is check her coordination in her lower extremities. So again, I'm going to have you take your heel, put it on your knee, cock your toes right back. So you're using the tip of your heel and running it up and down your shin between your knee and your ankle, and do it 3 or 4 times, nice and accurately. So again, I'm looking for rate, rhythm, direction, and force, and those are all nice and normal. Now switch legs. Okay, one more. That's very good. Excellent. I'm going to do joint position sense. So again, try and isolate the distal joint and demonstrate to the patient first that's up and that's down. Okay, so I want you to tell me which way it moves and close your eyes and guess. Again, big movements aren't necessary. It's a very sensitive joint. So here we go. You ready?
Up, up, down.
Well done. And we'll do this one here.
Up, up, up.
Good. And we'll do the same in the fingers. Okay, so again, isolating the joint here, up or down. So close your eyes.
Up, up, down, 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 down.
And you can see it's only about a 2-degree movement, so you don't need to really move it very large, or you'll miss some abnormalities. Again.
Up, 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 down, down, down.
So that's nice and normal. Okay, very good. So I'm looking for the vibration. It's a tuning fork, so let the patient know.
Detailed vibration testing will be demonstrated in a separate video.
And we're using a 128 tuning fork. So I want you to tell me if you feel a vibration or a pressure.
Okay. Pressure, vibration, pressure, vibration.
Good. So nice normal threshold. Let's do it in the fingers now. So vibration or pressure? Okay. Vibration or pressure?
Pressure,
Vibration or pressure?
vibration.
Very good threshold. So normal vibratory sense. First of all, Isobel, do you have any numbness or tingling of your arms or your legs?
No.
No.
If the patient has sensory symptoms, then a detailed sensory examination is required.
Okay, so I expect your sensory exam is going to be normal. So I'm using a toothpick, and that's what it would feel like.
Okay.
So I'm just looking for asymmetry. So you feel that,
Yes.
and you feel that.
Yes.
Ask the patient if they feel the sharp toothpick sensation, the same on both sides.
And that feel the same both sides?
Yeah.
Very good. Okay, let's do your arm now.
Yes.
Very good. Let's do this one. And that's the same both sides, and I expect that to be normal. Okay, very good.
If the patient has sensory symptoms, then a detailed sensory examination is required to determine if the sensory findings are related to nerve, root, spinal cord, or brain lesion. Review your nerve and root anatomy and sensory pathway.
Okay, as well, come on down. And what I'd like you to do is I'd like you to put your feet together and put your hands out in front of you. Great, and close your eyes. So we're doing the Romberg test, and again, with her eyes closed, she's nice and steady, and we're getting a chance to check for pronator drift, and I don't see any, and that's perfectly normal. That's great, thank you. That's excellent. So what I'd like you to do is just walk naturally for me up and back maybe 3 or 4 times, and let's take a look at what your normal gait is like. So what you're noticing is nice narrow base. Isobel's leading with her heel, which is nice and normal. And then if you will look at her arms, they swing freely and symmetrically. Okay. And then what I'd like you to do is just do a heel to toe walk, okay? And we're checking a cerebellar system there. So nice and steady, walking a straight line, and that's perfectly normal. That's great. Thanks, Isabel.